Good afternoon to all of us, and welcome to this week's presentation on evaluation and management of the first seizure in adults. To do this will be Dr. Henrietta, who will be taking us through this presentation. Like we always do, you realize that you'll be unable to unmute yourself all throughout the presentation. However, the chat box is available so that you can put in your comments, your questions as well, so that at the end of her presentation, we can have a discussion around it. At the end of the presentation as well, then you would be allowed to unmute yourself so that then you can ask questions or make comments and contributions. So kindly join me in welcoming Dr. Henrietta. Dr. Hetty, please unmute yourself and start.
Good afternoon. Good afternoon. My name is Dr. Henrietta, and I'll be presenting on the evaluation and management of first seizures in adults. My moderator is Dr. Katega Anyanah. So this is the outline of my presentation. We'll look at some definitions, the epidemiology, types of seizures, causes of seizures, some differential diagnosis, initial evaluation, additional testing, and the management. So these are some definitions according to UpToDate. We define a seizure as a sudden change in behavior which is caused by electrical hypersynchronization of neuronal networks in the cerebral cortex. We have what we call an acute symptomatic seizure, which is defined as one that occurs at the time of a systemic insult or in close temporal association with a documented brain insult. Also, we have what we call an unprovoked seizure, which is a seizure of unknown etiology, as well as one that occurs in relation to a pre-existing brain lesion or a progressive nervous system disorder. So the seizure that occurs in relation to the pre-existing brain lesion or a progressive nervous system disorder is sometimes referred to as what we call the remote symptomatic seizure. So epidemiology, is estimated that 1 in 26 people develop epilepsy during his lifetime. And the incidence of a single unprovoked seizure is 23 to 61 cases per 100,000 persons per year, while the incidence of an acute symptomatic seizure is 29 to 39 cases per 100,000 per year, with the highest incidence being in the extremes of ages. So what are the type of seizures we have? Seizures mostly are categorized into focal or generalized. Focal seizures being with retained awareness or with impaired awareness. Then we also have generalized seizures where there are several several types, and seizure of unknown onset as well. So here we'll talk about focal seizures with retained awareness. Previously, these seizures were referred to as what we call the simple partial seizures. And focal seizures, what we should know is that the impulse is usually generated in one hemisphere of the brain, and the presentation usually will be on the contralateral side of the affected brain. So the symptoms usually will depend on where the impulse is generated. So for example, when we have impulse in the, let's say the occipital cortex, we can have symptoms of flashes of light. With motor cortex, we have the Jacksonian seizures. Parietal cortex, we have spatial perception distortion. If it's located in the dominant frontal lobe, we can have sudden speech difficulties. So depending on where it's located, we can either have the focal motor, focal sensual, and focal autonomic presentations. So the focal seizures with retained awareness, usually post-ictal period, it results in the return of the person's pre-event base. There's return to the present baseline or a worsened neurologic function related to the location of the seizure in the brain. That is to say, let's say the person had a motor seizure involving the arm, so the arm becomes weak, third paralysis, it becomes weak after the seizure. This is a picture just showing some of the symptoms some of the how a focal seizure can present. For example, you can have the focal motor where you have the tonic-clonic movements shown up there. We have autonomic symptoms like sweating, flushing, auditory such as hearing ringing noises. You can have somatosensory such as tingling of the contralateral limb and face or side of the body, depending on where the insult is, then the presentation such. So also we have focal seizures with impaired awareness. These seizures were previously termed complex partial seizures, and they usually last about 3 minutes. Mostly these people who have focal seizures with impaired awareness usually can start with a state of them being zoned out. They can just be staring. They're not responsive to any instructions or words. They can also have some repetitive movements, such as that is automatisms like blinking of the eye, wetting of their lips, and all of this. And in some patients with impaired awareness, focal seizure with impaired awareness, they may begin with a phase of preserved awareness. So in such cases, after the event, they're able to recall probably the aura, but not the ictal phase itself. And usually the post-ictal phase is characterized by somnolence, confusion, and headache for some hours. Here's just a picture showing some of what I spoke about. Talk about the impaired consciousness. They're in a dreamlike state, blank, vacant expressions. They will have the automatism shown, the wetting of the lips, smacking of the lips, and all of that. So now we go to the next type, generalized seizures. Generalized seizures, the most common being generalized tonic-clonic seizures, which was previously called the grand mal seizures or major motor or convulsions. They usually begin with an abrupt loss of consciousness. It can be followed by a loud scream or cry. Then you have the tonic phase where there's increased tone in all the muscle groups, followed by a phase of convulsions, which is the clonic phase. Then afterwards is a phase of the post-ictal phase where there's sleep. They can sleep for some few hours. They might even wake up confused and agitated. And also we have under the generalized seizures, absent seizures, previously called petit mal, which usually occurs in childhood. They can occur in clusters. The people who experience this can usually let's say they're walking, then suddenly they'll just stop doing whatever it is they're doing just for a few seconds and return to normal. And they can occur several times in a day. Also, we have clonic seizures, which can affect different parts. The myoclonic seizures, muscle, atonic seizures, where there's loss of tone in the muscle groups, causing the patient to fall down. Tonic seizures, where there's increased tone in the muscle groups, which can also cause patients to fall down when they experience this. So this is just a picture showing the tonic phase and then clonic phase. So this here is a classification which was brought up by the International League Against Epilepsy in 2017. It just goes to talk about what I spoke about. You have the focal onset, which is with retained awareness and impaired awareness, where we can have of motor onset and non-motor onset. Also, we have what we call the focal to bilateral tonic-clonic seizures, which I forgot to mention. In this type of seizures, it usually starts with a focal seizure, which can be very abrupt, or sometimes it can be of slow progression. Initially, they used to call it the secondarily generalized seizures, but now it's termed focal to bilateral tonic-clonic seizures. Then under generalized seizures, you can have the motor and non-motor, which is absence, and of known onset, where we also have motor and non-motor, and also have unclassified as well. So now we go to the causes of seizures. What are some of the causes of seizures? In an acute insult to the brain, the most common causes here, we have bleeding, hemorrhage, where you can have subarachnoid hemorrhage, we can have intracerebral hemorrhage, subdural hemorrhage, we can have strokes, whether ischemic or hemorrhagic. A traumatic brain injury as well can cause seizures. Hypoxic ischemic injury as well. Infections, brain abscess, meningitis, encephalitis, they can cause seizures as well. We also have some metabolic causes where we have hyper and hypoglycemia. more common in hypoglycemia as compared to hyper. Then hyponatremia as well. In hyponatremia, in severe cases, it can lead to increased mortality. So it's always good to identify your cause early in order to prevent such. Another cause can be hypocalcemia, hyperthyroidism. Withdrawal states too can cause seizures. Alcohol withdrawal, usually seizures that occur with alcohol withdrawal occur within some hours, about 6 to 48 hours of stop of intake of alcohol. Substance withdrawal as well, and medication withdrawal. Some medication withdrawal such as ethanol too can cause that. Then we can also have some drugs that can also cause seizures. There are a lot of drugs we routinely prescribe in our facilities, but some of us actually not aware they can cause seizures. For example, we can have metronidazole, some penicillins, aspirin. They can all cause seizures. So next, we'll look at the differential diagnosis when it comes to seizures. Seizures are primarily diagnosed clinically, most cases. So in order to do that, we have to make sure we rule out other conditions or diseases that can mimic a seizure, that has the same presentation as a seizure, in order to prevent the wrong diagnosis and starting people on medications when they are not supposed to be on. One of such causes, we have syncope. Syncope, a transient ischemic attack, migraine as well, especially migraine with aura, panic attack and anxiety, psychogenic non-epileptic seizure. With psychogenic non-epileptic seizure, they typically present similar to seizures. The only difference is their origin is not neurologic in nature, it's mostly somatic. So mostly to differentiate it, an EEG might be of essence here. You can also have some transient global amnesia, especially in the elderly, narcolepsy and cataplexy, because looking at the presentation of seizures, the post-ictal states can make you confuse the narcolepsy, cataplexy as the person is in the post-ictal state of a seizure. You can also have some paroxysmal movement disorders, such as the dyskinesias, atetosis, and all of that, because they have paroxysms of movements of maybe some parts of their body. You might mistake that as a seizure occurring. So initial evaluation of someone who presents to you with a seizure, it's very important to take a detailed history. Because like I said earlier on, the seizures you will diagnose it, it's primarily diagnosed clinically. So it's good for us to take a detailed history. When someone comes with a seizure, maybe someone comes in they've had a seizure, or someone is brought in with history of a seizure, it's good to ask the person first to describe the event. If the person is able to describe the event vividly, tell you everything that happens, it can narrow you down to, okay, this is a focal seizure with retained awareness. If probably the patient is not able to describe the event, it will lead you towards the others, or maybe the patient is able to remember the beginning of it, it can lead you to a focal seizure with with impaired awareness. Also, sometimes if they're not able to describe, you can ask the person who was present during the seizure to tell you about it, maybe to describe. And if they're not able to describe, you can ask them pointed question. You can ask them, or maybe, was the person stretched out? Was there some jerky movements? How long did the seizure last? All of that will help to narrow you down to what type of seizure it might be. Also, the post-ictal period too is also very important. So you can ask about the post-ictal period. Maybe there's weakness in a part, the person slept excessively, the person has headaches and all of that. It's very important as well. Now you can ask about seizure precipitants and triggers. For seizure precipitants and triggers, it's not something that is common in all patients who present with seizures. There's just a few people who might have this trigger. So you can ask about triggers such as maybe some loud sound, some bright lights, or even some, change in emotional states. as well. You also need to ask about medications and substance use, because just like we know, causes of seizures, we have these medications and substances. So it's good for you to know about that. Also, you ask about the past medical history, which is very important. Maybe a history of a stroke, a history the person has a tumor. All of this will help to narrow you down on what you're dealing with. And a family history as well is very important. Because a family history of seizures, there's a possibility it can be inherited. So you getting to know about that will be helpful. Now, also have growth and developmental history, which is also very important, because maybe during development, the patient probably had all these paroxysmal movements and all of that. It's important as well. So next, we'll still continue with the evaluation, physical and neurologic examination. For physical examination, mostly it's how do you call it? It's not like you're going to diagnose with physical. No, it helps, it gives you an idea. For example, someone who might have a tonic seizure or atonic seizure, or even a generalized tonic-clonic, might have damaged parts of their body. They might maybe have some dislocations by their tongues and all of that. So physical examination can reveal this. It doesn't necessarily mean someone who comes with a dislocated, maybe shoulder, actually had a seizure, but it helps. Neurological examination too is very important, because most times, like I said about the stored paralysis, when there's a weakness in the part, probably is due to a seizure, and the weakness still persists. And you can find that at the time of examination. It's also important for us to do some lab testing. So like I spoke about hyperglycemia being a cause, it's best to check. One of the things you should always check quickly is the RBS, because we know hypoglycemia can kill people fast, and it's easy to correct it. So you do your RBS, check for various calcium, magnesium, electrolytes, toxicology, screen as well, renal, liver functions, and also serum lactate. The thing about serum lactate is that for serum lactate, it sometimes can help in, it can sometimes help to determine whether the cause is a generalized seizure, whether the seizure is a generalized seizure or a psychogenic non-epileptic seizure. The levels might be elevated within 2 hours. Serum prolactin too can help, however, it's not very sensitive like that. Then an ECG, all patients who come with history of seizure, it's important to do an ECG for them, because like I spoke about the differentials of a syncope. It could be that the person probably had an arrhythmia and had a syncope, and you'll be thinking it's a seizure. We'll have to correct whatever we find. So additional testing we can do, a lumbar puncture. So in patients who present with seizures where you think the cause is infectious in origin, CNS infections, you would want to do a lumbar puncture to determine that. Then it's also important for us to do EEG. So the EEG, it's it's an essential study to evaluate whether the person has epileptic seizures or not. That's one thing. And neuroimaging, that's the MRI and CT scan. It's a must for you to do neuroimaging for all patients who present with a first seizure, unprovoked. So now we'll talk about the management of seizures. Seizures typically, the self-abort within a few minutes. So most times there's not really a need for us to give some rapid acting anti-seizure medication like this. That's the pump we typically use in our setting. But when someone presents with a seizure, history of a seizure, it's important for you to always obtain IV access, and so that in case there's another seizure occurring, you can easily abort it. Then you identify the underlying cause and treat as such. So in case of hypoglycemia, you correct it. In case of all these electrolyte disbalances, you correct it. So next we'll look about on when to start anti-seizure medication. Because just like you know how, like I spoke about in the beginning, the definitions, if someone has an acute asymptomatic seizure, when would you want to start seizure medication on such a person? So all of this would depend on a lot of things. You look at the probability that the event presenter is actually a seizure and whether the suspected or confirmed cause, and the suspected or confirmed cause of the seizure, the stability of the patient, and the estimated risk of recurrent seizure. So based on this, the decision to put the person on under anti-seizure medication will depend on what you find. For example, in critically ill patients, when you know that seizure recurring will impair their recovery, you would want to keep the person on anti-seizure medication to prevent subsequent seizures in order to allow for the person to recover. Well, for example, let's say someone has a stroke and has a seizure. Recurrent seizures will definitely affect the patient. So we want to put on a seizure medication in order to allow for the patient to recover. Also, in patients who have seizure which is provoked by metabolic derangement, you may also want to put the person on a short-term anti-seizure medication because definitely if the metabolic derangement is still ongoing, there's a risk that the person will have another one. So still continuing on when to start a seizure, in unprovoked seizures, when to start anti-seizure medication. Okay. Sorry. Okay, so sorry, I was unmuted, so I didn't know about that. So like I said earlier on, the decision to start medication in patients who have had an unprovoked seizure where they return to the baseline is more complex. It's more complex because it has been noted that approximately 1/3 of such patients will will have a recurring seizure within 5 years, and the risk is increased to 2.5-fold in association with the following: an epileptiform abnormalities on an interictal EEG, a remote symptomatic cause as identified by clinical history or neuroimaging, an abnormal neurologic examination, including focal findings and intellectual disabilities, and a first seizure that occurs during sleep. So in
Sorry, Haki, your slides have gone off. Kindly share and then take it from there. I sent a message, but I realized you didn't read it. Yes, all good.
Okay. So like I spoke about, in this patient with unprovoked seizures where there's return to the baseline with the risk factors I mentioned earlier on, there's a risk of recurrent seizure that approaches or exceeds 60% over the next 10 years, thereby meeting the criteria for epilepsy according to the International League Against Epilepsy, their definition of that. And in such patients, you would want to start it's the start of anti-seizure medication. There's a strong base for you to start anti-seizure medication. Either you start at where they are met or with consult with a neurologist. However, in patients without the risk factors, the decision to start is what do you call it? There's not really a strong basis for you to start, but it will depend on the patient as well. If the patient might actually want to, maybe you do so in consult with a neurologist. Okay, so this slide just gives examples of anti-epileptic drugs that's commonly used. These drugs, their mechanism is based on the pathophysiology of seizure generation. Some act on the sodium and calcium channel, inhibiting them. Then GABAergic, which will agonist, because GABA is more like a inhibitor, so it will cause decrease impulse generation. Then glutamate, they'll act against glutamate receptors because glutamate is more of an excitatory neurotransmitter. Then calcium inhibitor as well. So examples here, you can see phenytoin, carbamazepine, etoposide, sambabiturate, benzodiazepines, and of unknown origin, we have levetiracetam. You can take your time and go through it later. And here are more of the drugs mentioned, their mechanism of action, some indication, side effects, because we know some individuals we meet, especially in our setting, we have a lot of people with some liver disorders. So depending on how the drug is metabolized, it might help you narrow down what medication you administer. So next under management is, when would you want to hospitalize someone who presents with a seizure? So anyone who presents with a seizure with prolonged post-ictal states, you would want to admit the person for further investigation, or has not completely recovered, you would want to definitely admit. Someone who presents with status epilepticus, you'd want to admit. That's a seizure which goes on for more than 5 minutes, and maybe you have multiple seizures without, returning to the normal, in between the two seizures, you've not returned to the normal and another seizure occurs. Also, presence of a neurological systemic illness or insult, which will require additional evaluation treatment, you admit the patient. Compliance as well. When you have issue with compliance, you want to admit. In a prolonged seizure for more than 5 minutes, you want to admit. So what are some of the indications for a referral for someone who comes with a seizure? So majority of patients with the first time seizure should be evaluated by a neurologist, unless obviously you know the seizure is provoked by an acute, state. Then it's not, most likely you wouldn't want to, because after you resolve the acute state, the risk of recurrence is very low compared to unprovoked seizures. And what are some of the seizure precautions you want to give patients? You would want to tell them about the common triggers, especially in those who have the triggers. Talk to them about sleep deprivation, alcohol, how infectious can trigger that, some drugs, and all of that. And also you want to educate them about their lifestyle. They should make sure they are not, they don't do some things unsupervised, like swimming, tall, working at heights, because when they have the episode, they can easily fall down or drown. These are my references. Thank you.
Great. Thank you very much, Dr. Hetty, for an excellent job done. And thank you, participants, for joining us today for this presentation. We'll be able to do this in less than 30 minutes. So that then allows us a lot of time for questions and comments. Just before we move on to that session, if you look in the chat box, I've just put up a link there. Kindly click on it so that you help us evaluate today's presentation. It helps to evaluate the presenter. It helps to tell us for future plan and what to do. And then more importantly, also ask for your suggestions towards improving these presentations. It takes just about a minute of your time. So whilst we prepare to move on to the Q&A session, kindly click on this link again. Make those responses, and more importantly, then you put up the suggestions going forward. As well, those who would want to have the PDF version of this presentation, you could leave your number in the suggestion. As well, you could leave your email there so that they can mail these to you. Also, the presentations are recorded, so they would be available at the GhanaMedicalHelp.com website. So if you click on that, you'll find all of them. Again, if you go on our YouTube channel, you'll find that these presentations are there, so that in the comfort of your home, you can go through them the way you would want. So once again, a kind reminder to click on the link I've just put up in the chat box to help us improve upon our presentations. It will take you just a minute of your time to do this. So kindly do this to help us. We'll just allow some 5 minutes so that people can complete this survey, and then we'll move on to the Q&A. Whilst we are waiting for that, if you are done with the survey, you could put in your question in the chat box so that then we address it. Otherwise, if you are done and we want to ask by way of speaking, you could electronically raise up your hand and then I would unmute you. Please don't put your number in the chat box. Just click on the link I've put there. And then at the last column, you see the question is what your suggestions for future programs like this, what we should cover. And I'm saying that in addition, you could leave your email there and then this presentation will be sent to you. Also, you could easily access it on the YouTube channel, GhanaMedicalHelp.com, Ghana Medical Help handle, sorry. And then if you log on to the website, GhanaMedicalHelp.com, you have both the PDF and then the audio version of what's recorded here. So don't leave your number in the chat box. Just click on the link I've put in there and then provide the responses. And then at the end of it, you can leave your number in there and then you get these sent to you or your email in there. If you want to put in a question, a suggestion, or you want to ask a question, you could probably electronically put up your hand and then we would unmute you to do this. So there are a couple of questions that have come up in the chat box. We would allow just a minute or two for people to finish the survey and then we'll go ahead to answer these. Hetty, you could unmute yourself. All right, I'm sure most people are done with the survey that I've put up because it just takes about a minute or so. There are direct responses to them. And at the end of it, you could leave your email address so that we mail the PDF version of this to you. Okay, so Hetty, let's address the issues from the chat box. The first one is from Senam Amable. Says, good afternoon, please, I would like to get the slide for reference. Great, so just like I communicated, click on the link of the survey I've just put in there, provide your responses, and at the end of it, leave your email address in there, and then this will be sent to you as well. If you want to use the YouTube channel, you click on, you enter Ghana Medical Help, and you have access to the same presentation that is being recorded. Again, if you want to visit the website, it's ghanamedicalhelp.com, and then you'll be able to access this presentation in addition to all the previous presentations we've made. So thank you, Amable, for your comment. The next one is Richard Pra. He asks, how long can we say the post-ictal state is prolonged as an indication for hospitalizing the patient? Dr. Eti.
Okay. So for the prolongation of post-ictal phase, it will typically, it's supposed to return, let's say, in 5 to 30 minutes. However, it might be dependent on the person's, let's say, clinical presentation. Then let's say the person has an acute condition, maybe the return to the baseline might take a longer time. And then depending on the age groups as well, it might take longer than that. But in most cases, within 30 minutes, there should be a return to the baseline.
Great. So I agree with you. Typically between 5 to 30 minutes is also. And obviously anything out of that, especially in the setting of a seizure, you say that definitely the person has a prolonged post-ictal phase. You actually have some people in the post-ictal phase for even up to a day or even more. So this obviously is a prolonged post-ictal phase. Okay. Let's see. I don't see any other comment. So Godfred Ajimai says, please, I'll need the slides. Yeah, so just like I communicated, same method. Please click on the link that I've put in there, provide your responses. On the last comment, you leave your email address, we'll mail this to you. Thank you, Godfred. Then number 952 says, what's the difference between seizures and convulsions? And how do you differentiate epilepsy from these two? Okay, so the first one is, Hetty, is there a difference between seizures and convulsions?
Convulsions typically, I think the chronic, what you call it, seizures are usually termed convulsions. And to differentiate, a seizure might not present as a convulsion because there are different types, like I stated earlier on. Yes.
Okay. Yeah, so sometimes people use the word interchangeably. So definitely we need to be careful when it's used in the general context, because most people refer to all seizures as convulsions, and also. So it's more of a general term that people usually use. For any kind of uncontrollable muscle spasms, people will typically do that. But in the true sense of the word seizure, like Hetty said, obviously, usually it refers to the electrical disturbance in the brain that then gives you the clinical manifestation that you have. So seizures may actually cause someone to have the convulsion. That is the uncontrollable muscle spasms, like you saw in the different types that she had mentioned. And some seizures may not necessarily result in the clonus or any of that. So if in the general context, like a patient walks up to you and say, my child had a convulsion or any of that, I'm sure the person is referring to a seizure. But in the strictest of terms, when we're talking about seizures versus convulsion, is yes, as Dr. Hetty has told us. The second part of his question was, how do you differentiate epilepsy from seizures?
Okay. So for you to say someone has an epilepsy, the person should have at least 2 unprovoked seizures, which occur with maybe a 24-hour interval. That's for you to say someone has an epilepsy. Yeah.
Okay.
That usually
So,
can be, a seizure can either be unprovoked or provoked, like an illness, acute illnesses.
Yeah, great. So obviously there are strict guidelines regards to defining epilepsy. And if you qualify or you fall into that, then we say you have epilepsy. But seizure is just as she has explained. There are actually 3 that have been proposed by the International League Against Epilepsy. And so it is not right that somebody has a seizure and it's a first-time seizure, and then you make a diagnosis of epilepsy if it doesn't meet any of these 3. Those are the first one, at least 2 unprovoked seizures, which occur more than 24 hours apart. That's the first one. The second one was anytime you make a diagnosis of epilepsy syndromes, especially in children. And the third one is when you have 1 unprovoked seizure, but you have a more than 60% risk of getting another seizure. So if you have 1 unprovoked seizure, and then the risk of you getting another one is more than 60%. Typically, the way to determine whether your risk is higher is definitely if you have a structural brain lesion. So you realize those who have stroke, when they come in with a first-time seizure, we start them on medication because the simple diagnosis is that it's likely that this person has epilepsy because he has 1 unprovoked seizure. And the second criteria definitely is that his risk because of the structural brain lesion puts him at a more than 60% risk of getting another seizure. So these are the strict criteria that you can use for epilepsy. The seizure is as she has beautifully explained. Great. Richard says, how can one clinically differentiate between generalized and complex seizures? Your question is a bit of a problem because you are mixing the new terminology with the old one. So seriously, the ILAE, just to make things clearer, doesn't shy away from the use of things like simple, partial versus complex and all of that. So if you could kindly come clear, it would be easier. If you look on the table that she put up, the new classification, I think since 2017, is just for you to know whether this is a focal or a generalized seizure. Is this with impaired awareness or there's no impaired awareness? That's all about it. Then Dr. Debo asks, Dr. Betty, great presentation. Really, Evans, this is not Betty, it's Hetty. I would like some clarification on the duration of status epilepticus. Some schools of thought have mentioned continuous seizures more than 30 minutes or 2 or more seizures without a full recovery between them. Is this any different from the 5 minutes duration you mentioned? Okay, Hetty, please respond to him.
Okay, so from my reading, the duration usually is more than 5 minutes of ongoing of a seizure. And the second, like I spoke about, when there's multiple seizures without returning to the normal, 2 seizures without returning to the normal in between the 2 seizures. That is what I found out.
Yeah, so you're right. I think Evans was probably, I don't know if it's mixing up the post-ictal phase versus what you have described as the status epilepticus in seizure disorder. So typically it's just as you have said. Again, the diagnosis of status epilepticus, like any other seizure, is usually more of a clinical entity. And so typically, once the duration is more than 5, and then the seizure is not aborting, typically they will say that this is status epilepticus, and you would wish it's a medical emergency, and you would wish to have this sorted out ASAP so that then the damage doesn't keep on going on and then cause a lot of issues. Okay, let's move on. Then Richard, can you highlight on some of the common seizure patterns and the drugs to administer and some few reasons for choosing some drugs over the other? I guess the table that you put up, if you can just highlight on the important parts of that table and then we'll move on.
Okay, so the table I put up, the most important when you come to focal seizures, Boss, please, the question again.
So it's looking at the drugs to administer in which seizure.
Okay. Okay. So if you look at some of the drugs here, you find that in the terminologies are still the simple partial, but we know how it's differentiated. So mostly in focal seizures with retained awareness, you can use carbamazepine. Focal seizures in general, you can use carbamazepine, you can use phenytoin, levetiracetam and lamotrigine can be used in all seizure types. In abscess seizures, you use etazizumab. In both focal and generalized seizures, you can use phenobarbital, and pregabalin can be used in both focal and generalized. In the acute setting, you want to use something that is medication that is fast acting. You typically we use diazepam. However, if you give diazepam is not working, you can move up to phenytoin, which I indicated it can be used for both focal and generalized. And you can go up again to maybe phenobarbital if it's not working as well.
Okay, great. Next one is, please, can hyperthermia lead to convulsion or seizure?
Yes, hyperthermia can lead to seizures, especially in, fever, especially in children. As I think, in pediatric, we talk about febrile seizures as well. So it can lead to.
Yeah, so febrile seizures, then also. And that as well can worsen seizures when it is there. Then Richard says, I also heard that status epilepticus can be defined in terms of the number of anti-epileptics used. And can you highlight on this for me, especially which of the medicines, at what point you say it is status epilepticus? Any that you've come across, Hetty?
No, please.
Okay. So if we want to play by the strictest of definitions, there's what is referred to as the operational definition of status epilepticus. There's what in the International League Against Epilepsy also have a definition. If you want us to go over this, I could just make a reference to it and then we'll look at. The operational definition is usually that one, the seizure is more than 5 minutes continuous, like we just talked about. Or if you have two discrete seizures between which there's incomplete recovery. So you don't get back to the baseline like Dr. Hetty mentioned, and then you have another one. So greater than or equal to 2 of that. And then if you are looking at the International League Against Epilepsy, they look at if the first seizure at time 1 is the time that the ongoing seizure activity should be regarded as the abnormally prolonged, and it unlikely stops. And when treatment, so the seizure doesn't stop by itself. The duration passes the 5 minutes, and then you start treatment. And with that, they will refer to it as status epilepticus. And then another one is at time T2. That's the time that the ongoing seizure activity poses a significant risk for long-term complications. So essentially, it's just about the duration of time. So commonly, in terms of anti-seizure medicine, if you start the anti-seizure medicine and then the seizure doesn't terminate, obviously it will go against this 5 minutes that we've talked about, especially if you are using the ILAE classification, which uses the time T1 and T2. The T1 is the 5 minutes that we've talked about, and T2 is usually 30 minutes. That's where then it poses a significant long-term complication. So definitely, if you're using anti-seizure medicines that the seizure does not terminate and it is within this period of time, you can say that it's status epilepticus, and obviously you have to treat as such. Okay, so those are all the questions in the chat box. If anyone has a question, you could kindly electronically raise up your hand and we'll mute you to talk. Kind reminder again that you can take part in the survey to help us to evaluate what we have done. I've just put up the link for that survey in the chat box. You could click on it and then you provide your responses. Kindly electronically raise up your hand, and then I'll unmute you if you have a question. No hand up. If you have a question, please electronically raise up your hand. I'll unmute you and you go ahead. No question? Okay, so in the absence of any question, I would want to say thank you to all of you for joining us for today's presentation. We'll be able to do this in under an hour, and hopefully next week we would look at another topic. Take care and God bless us all. Bye-bye. Also, thank you to Dr. Hetty for a great job done. Bye-bye.